To open the next session, please welcome Professor Manuel Francisco Roxas, Director of the Commission on Cancer of the Philippine College of Surgeons. He is also the President of the ERAS Society Philippines, ASEAN Society of Colorectal Surgeons and Philippine Society of Colorectal Surgeons.
Good evening, ladies and gentlemen. I am Dr. Manuel Francisco T. Roxas. I am currently the Director of the Philippine College of Surgeons Commission on Cancer. The next lecture is entitled Colorectal Cancer Surgery, Updates in the Genomic Era. Our distinguished speaker is Professor Hwan Lee, Professor of Surgery at Kyunghee University Hospital in South Korea, and past Secretary General of the Korean Society of Endoscopic and Laparoscopic Surgeons. At present, he is the Editor-in-Chief of the Journal of Minimally Invasive Surgery and Chair of the Public Relation and Advertisement Committee of the Korean Society of Coloproctology. His clinical practice is focused on colorectal disease, especially laparoscopic colorectal cancer surgery. He is currently involved in prospective clinical trials on the feasibility of single-port laparoscopic colorectal surgery. Ladies and gentlemen, please welcome Professor Hwan Lee.
Good evening, ladies and gentlemen, Mr. Chairman. I'm Hwan Lee from Kyunghee University Hospital, and now representing the Korean Society of Coloproctology as the chairman of the board. I am privileged and honored to have an opportunity to talk at the AOS2020 virtual meeting. I appreciate the organizing committee of AOS 2020 for a kind invitation. The topic of my talk today is too much complicated for me. I will just highlight some historical moment of colorectal cancer surgery revolution. I have no disclosure. After the successful management of melanoma with immunotherapy, it became a huge research and clinical interest among many oncologists. The role of immunotherapy in colorectal cancer management is just the beginning compared to the lung cancer management. The actual start of the modern surgery began after the introduction of general anesthesia in 1846, and we surgeons work more hours after the invention of electric light in 1879. Before the invention of electric light, the operation was done only during the day, rely on the sunlight. With this tradition, we surgeons still start our work very early in the morning. This slide illustrates the many historical turning points of rectal cancer surgery and also shows the dramatic improvement of surgical outcome. After the introduction of mild operation in 1908, the recurrence rate decreased more than 50%, and after Professor Heald highlights the concept of TME, the local recurrence rate dropped it even more, around less than 10% at the most now. The contribution of Sir William Ernest Miles in the field of rectal cancer surgery is no matter how much we emphasize. After the perineal resection of rectal cancer in early days of his career, the recurrence rate was 95%, and he found that the upward lymphatic spread causes the recurrences. He proposed the abdominal perineal resection with envelope lymphadenectomy in 1908 with low ligation of inferior mesenteric artery. The operative mortality was 36%, but if you imagine there were no antibiotics and transfusion available at that time, the result was amazing. This slide shows the original article from Sir William Ernest Myers. He emphasized the complete eradication of downward upward spread of cancer from the rectum. Another important surgeon in Myers' era was Lord Berkeley Moynihan. He was from the city of Leeds, UK. He emphasized the surgery of the malignant disease is not the surgery of the organ. It is the anatomy of the lymphatic system. Furthermore, he proposed high ligation of inferior mesenteric artery for the rectal cancer surgery. As you can see, the debates about the level of ligation of IMA in rectal cancer surgery started from the very beginning of the rectal cancer surgery innovation. This debate has been recently resolved with meta-analysis indicating no differences in oncologic outcomes between low and high ligation of inferior mesenteric artery. Dr. Tumber from Cleveland Clinic is also very famous for his concept of no-touch isolation technique. He established the surgical oncologic principles with early ligation of vascular pedicle and luminal cutting before mobilizing the tumor compartment. He reported the oncologic superiority of no-touch isolation technique in 1967. This result stimulated many surgeons consider the oncologic surgery. Minimally invasive surgery or transluminal surgery became a routine practice now. However, without a contribution of Dr. Bues, transluminal or natural orifice surgery will not start. He invented transanal endoscopic microsurgery unit in 1980, and this instrument at that time was already 3D in the vision. The role of TME in rectal cancer surgery is too boring to talk. In 1982, Dr. Hield proposed sharp dissection of mesorectum, and it became a standard technique for the rectal cancer surgery now. We should correctly preserve the fascia propria of rectum to the specimen side with high vascular pedicle ligation. Whole mouth section histologic examination of the specimen is also critical to ensure the circumferential margin evaluation. The important tip of TME are careful, sharp dissection around IMA, posterior dissection in the presacral space, entry to this space by sharp dissection immediately posterior to the superior rectal artery, and removal of the entire mesorectum from low rectal cancer. The TME concept was further evolved to colon cancer surgery, namely complete mesochoric excision with central vascular ligation. Dr. Hohenberger emphasized the operation through the embryologic developmental planes. His operation was open approach, but we now perform the same approach with laparoscopic surgery. As you can see in this slide, the lymph node lies in the visceral mesochoric fascia. However, there are some concerns about the complete mesochoric excision and central vascularization concept. I don't think this is a brand new concept in right hemicolectomy. We can apply the same concept to all colon cancer surgeries. Cochlear maneuvers to dissect the retropancreatic node is unnecessary in right colon cancer surgery because the retropancreatic nodes did not lie in the embryologic developmental plane of lymph node drainage. This is also true for the infrapyloric lymph node in hepatic fracture cancer surgery. We usually do not routinely dissect infrapyloric lymph node dissection during the extended right hemicolectomy for the hepatic fracture cancer regions. Dissection beyond the arterial origin of superior-mesenteric origin from the superior-mesenteric artery also seemed too much dissection, I guess. However, the introduction of CME with CVR technique in colon cancer surgery has many roles, such as standardization of corectomy, more meticulous lymph node dissection. It makes better prognostication with more accurate staging. Transanal TME was introduced to overcome technical difficulties of transabdominal TME more than 10 years ago. Professor Hill mentioned about this technique is truly an exciting prospect for the future. Now we have more platforms for successful and safe implementation of transanal TME. We can identify and dissect through the holy plane exactly the same as the transabdominal TME. An international expert consensus guideline on indication, implementation, and quality measure for transanal total mesorectal excision was published recently. International experts agreed the quality and outcome measures, the necessity of the formal training, and its technique. Unfortunately, they do not reach fully in the indication of TATME procedure. As you can see in this slide, some indications of the TATME did not full agreement among experts, such as transanal approach could be used if completion TME is indicated after previous full thickness local excision, like that. I think TME, not TATME, should be the principle of surgery for the rectal cancer when it is safely performed by the surgeon. For the successful implementation of TATME, training and proper proctorship are mandatory. There are some merits and demerits of the transanal TME. Many TATME reports describe the shorter operative time. However, the shorter operative time result from two-team approach of the procedure, not the TATME procedure itself. The most surgeons agreed TATME provided a longer distal margin because this technique started from the below to ensure the distal margin first. There are some concerns about the good quality of the specimen with the TATME and safety of the procedure. I do not think the TATME will provide better functional outcome after surgery than transabdominal TME because this operation is the approach matters, not function preserving matters. From the international registry report, the height of the anastomosis was low as 3 centimeters for hand-sewn and 4 centimeters for stapled anastomosis. Some adverse events included such as technical problems, incorrect dissection plane, pelvic bleeding, and visceral injuries. Sorry. These events can occur the same in the transabdominal approach. From the multivariate analysis of international registry data, no obesity, but lower tumor location and positive circumferential resection margin is related to poor operative quality. Difficult abdominal dissection, less than 4 centimeters, showed a significant factor in the poor operative quality. It means, I think, TATME is still difficult procedure for low located and bulky rectal tumors. Geographically, Norway and Netherlands are not that far away. However, the attitude toward the TATME is quite different. In January of this year, a study from Norway reported worrisome result of the TATME. The local recurrence rate was 7.6%, and 8 out of 12 patients showed unusual recurrence pattern such as multifocal and extensive recurrence in the pelvis. Anastomotic leak rate was as high as 8% compared to the 4.5% in transabdominal TME, and 25% of stoma deemed permanent. So we are waiting for the more studies such as the color 3 result to determine the oncologic safety of TATME. The treatment paradigm for rectal cancer is changing rapidly. The role of surgery is challenging, not only in the field of oncologic surgery, but in benign disease as well. With the introduction of effective cytotoxic and target agents such as oxaliplatin and bevacizumab in early 20s, the proportion of surgery in patient care of the colorectal cancer is decreasing rapidly, as you can see in this slide. In 1987, the palliative resection rate for stage 4 colorectal cancer patient was 74%, and now it decreased around 57%. However, still, we think surgeons still operate more than we expected. Ladies and gentlemen, Mr. Chairman, I'd like to conclude my talk with Dr. Katie's famous word. In the world of surgical oncology, the biology is king, selection of cases is queen, and the technical details of surgical procedures are princes and princesses of the limb. So, thank you very much for your kind attention, and I really hope next time we can meet face to face. Keep safe and healthy. Thank you very much.
Good evening. I'd like to apologize for that technical glitch. I had to reload my page. I hope you can hear me now. So I'd like to thank Professor Hwan for his very interesting lecture. He spoke about the development of colorectal cancer surgery from its early days in the early 1900s up to the present time, and where minimally invasive surgery, of course, is taking root. I guess he has shown that the basic principles of colorectal cancer surgery remain, which is good lymph node clearance or adequate lymph node clearance and very good margins. However, there are some controversies that remain as we progress and evolve in our surgery for colorectal cancer. There are some questions I think that I would have wanted to pose to Professor Hwan. For instance, in Korea, I know robotics is a very strong skill that they do for colorectal cancer, and its role in the ASEAN region, in Asia, is something that is still under investigation as to whether it is cost effective. The role of neoadjuvant chemotherapy and radiotherapy is also something that is evolving, and he did mention that for stage 4 colorectal cancer, the role of chemotherapy has lessened the need for palliative surgery, which is good. But certainly there is a lot more data that we need on whether neoadjuvant chemoradiotherapy in its various protocols and formats may indeed improve outcomes for rectal cancer, and neoadjuvant chemotherapy also for colon cancer. I think more moving in that direction will require a deeper understanding of the molecular profile of our colorectal cancer patients, and in which patients are more feasible to be given either chemotherapy or immunotherapy. And then finally, Professor Hwan talks about the controversy regarding TA-TME and its questionable outcomes compared to traditional and laparoscopic TME. And is this an issue of just learning curve, or is it inherent in the technique that we will get poorer outcomes? So a lot of controversies remain, but I think Professor Hwan has shown that the progress in colorectal cancer surgery has indeed been quite dramatic compared to what it was before. But certainly a lot of growth, a lot of understanding, and a lot more techniques in surgery, as well as in the developments of chemotherapy, immunotherapy, and maybe the protocols in radiotherapy remain. Thank you for your attention, and I'll leave it here.